Lecture on Acute Kidney Injury, AKI Overview. Acute kidney injury, AKI, previously termed acute renal failure, is a sudden decline in renal function occurring over hours or days. It disrupts the regulation of waste excretion, fluid balance, electrolyte balance, and acid-base homeostasis. AKI is a spectrum disorder, ranging from mild kidney dysfunction to severe failure requiring renal replacement therapy. Kidney functions. Recap. 1. Acid-base balance. Maintains pH between 7.35 and 7.45 through bicarbonate reabsorption and hydrogen ion excretion. 2. Fluid balance. Adjusts urine concentration based on plasma osmolality. 3. Electrolyte balance regulates levels of sodium, potassium, and other electrolytes. 4. Excretion of waste filters urea and creatinine. 5. Blood pressure regulation through the renin-angiotensin-aldosterone system, RAAS. 6. Erythropoiesis secretes erythropoietin to stimulate red blood cell production. 7. Calcium and phosphorus regulation. Facilitates bone health by activating vitamin D. AKI classifications. AKI is categorized based on the underlying cause. 1. Pre-renal reduced renal perfusion due to hypovolemia, sepsis, or cardiac failure. Typically reversible if caught early. 2. Intrarenal. Direct structural damage to renal tissue caused by toxins, drugs, or prolonged ischemia. 3. Post-renal obstruction of urine outflow due to kidney stones, enlarged prostate, or tumors. Stages of AKI. The kidney disease. Improving global outcomes, KDI-GO, criteria classify AKI into number 1. Stage 1. Serum creatinine increase greater than or equal to 26 micromoles per liter within 48 hours, or 1.5 to 1.9 times baseline. Urine output less than 0.5 milliliters per kilogram per hour for 6 to 12 hours. Stage 2. Serum creatinine 2.0 to 2.9 times baseline. Urine output less than 0.5 milliliters per kilogram per hour for greater than or equal to 12 hours. Stage 3. Serum creatinine greater than or equal to 3.0 times baseline or greater than or equal to 354 micromoles per liter. Urine output less than 0.3 milliliters per kilogram per hour for greater than or equal to 24 hours, or anuria for greater than or equal to 12 hours. Risk factors. Number 1. Patient factors. Age greater than 65 years. Diabetes, hypertension, chronic kidney disease, or dementia. 2. Environmental and clinical factors. Sepsis, dehydration, hypotension, or nephrotoxic medications. 3. Hospital factors. Surgery, use of contrast agents, or prolonged ICU stays. Clinical features. AKI symptoms are often nonspecific and include reduced urine output, oliguria or anuria, nausea, confusion, or fatigue. Signs of fluid overload, such as edema, hypertension, or hypotension, depending on the stage and cause. Management. 1. Identify and treat the underlying cause. Pre-renal fluid resuscitation. Treat sepsis. Intrarenal discontinue nephrotoxic drugs. Address infections. Post-renal relieve obstruction, e.g., catheterization, surgery. 2. Supportive measures. Monitor fluid balance and adjust intake. Correct electrolyte imbalances, e.g., hyperkalemia. Address acid-base disturbances. 3. Renal replacement therapy. Indications. Severe metabolic acidosis, hyperkalemia, fluid overload, or uremic complications. Modalities. Hemodialysis. Effective but requires hemodynamic stability. Hemofiltration. Gentler, often used in ICU settings. Peritoneal dialysis. Home-based, uses the peritoneum for filtration. Prevention. 1. Early recognition of at-risk patients. Frequent monitoring of urine output and creatinine levels. 2. Medication review. Avoid or adjust nephrotoxic drugs like NSAIDs, ACE inhibitors, and certain antibiotics, e.g., gentamicin. 3. Hydration and nutrition. Maintain adequate fluid and nutritional support, particularly in vulnerable patients. Case study. A 68-year-old male presents with collapse, dehydration, and bilateral leg ulcers. His creatinine has risen from a baseline of 70 micromoles per liter to 145 micromoles per liter, stage 2 AKI. Management includes immediate fluid resuscitation, sepsis management, medication review, e.g., discontinue nephrotoxic drugs like diuretics, metformin, monitor potassium, bicarbonate, and acid-base status. Address the underlying infection or other precipitating factors. Conclusion. AKI is a critical condition that requires timely recognition and management. Prevention through risk stratification, early intervention, and education of healthcare providers can significantly reduce the morbidity and mortality associated with AKI. Always consider the broader systemic impacts and the patient's overall context in management. 50 questions and answers on acute kidney injury, AKI. General understanding of AKI. Number 1. What is acute kidney injury, AKI? AKI is a sudden decline in kidney function over hours or days, resulting in the accumulation of waste products, fluid imbalance, and disrupted electrolyte homeostasis. 2. What are the main causes of AKI? AKI can be caused by pre-renal, reduced perfusion, intrarenal, damage to kidney tissue, or post-renal, urinary obstruction factors. 3. What are the hallmark signs of AKI? Decreased urine output, oliguria or anuria, rising serum creatinine, and electrolyte imbalances. 4. What is the difference between AKI and chronic kidney disease, CKD? AKI is sudden and potentially reversible, while CKD is gradual and often irreversible. 5. Why is AKI considered a spectrum disorder? It ranges from mild kidney dysfunction to severe kidney failure, categorized into stages based on creatinine levels and urine output, kidney functions, and impact of AKI. 6. What are the main functions of the kidneys? Waste excretion, fluid and electrolyte balance, acid-base regulation, blood pressure control, erythropoiesis stimulation, and vitamin D activation. 7. How does AKI affect acid-base balance? It disrupts bicarbonate reabsorption and hydrogen ion excretion, leading to metabolic acidosis. 8. What happens to fluid balance in AKI? AKI may cause fluid retention, resulting in edema, and in severe cases, pulmonary edema. 9. Which electrolytes are commonly affected in AKI? Sodium, potassium, calcium, and phosphorus. 10. What role does the kidney play in blood pressure regulation? The kidneys regulate blood pressure through the renin-angiotensin-aldosterone system, RAS. Risk factors and epidemiology. 11. What are common risk factors for AKI? Age greater than 65 years, diabetes, hypertension, chronic kidney disease, sepsis, and nephrotoxic medications. 12. How does diabetes contribute to AKI? Persistent hyperglycemia damages kidney blood vessels, leading to diabetic nephropathy. 13. Why are elderly patients at higher risk of acute kidney injury? Reduced kidney reserve, comorbidities, and increased medication use. 14. What percentage of hospitalized patients develop AKI? Approximately 13 to 18% of hospitalized patients develop AKI. 15. What is the leading cause of acute kidney injury in hospitalized patients? Sepsis and hypovolemia. Classification of acute kidney injury. 16. What are the three main classifications of AKI? Pre-renal, intrarenal, and post-renal. 17. What is prerenal AKI? AKI caused by reduced kidney perfusion due to factors like dehydration or hypotension. 18. What is intrarenal AKI? Acute kidney injury caused by structural damage to kidney tissue, such as from toxins or prolonged ischemia. 19. What is postrenal acute kidney injury? AKI caused by obstruction of urine flow, such as kidney stones or an enlarged prostate. 20. Can a single patient experience multiple types of AKI? Yes, for example, prerenal AKI can progress to intrarenal AKI if untreated. Diagnosis and monitoring. 21. What is the most important biomarker for diagnosing AKI? Serum creatinine. 22. How is urine output used in diagnosing AKI? Oliguria, less than 0.5 milliliters per kilogram per hour, is a key diagnostic criterion. 23. What is the KDIGO definition of AKI? Increase in serum creatinine by at least 0.3 milligrams per deciliter in 48 hours, or at least 1.5 times baseline within 7 days, or urine output less than 0.5 milliliters per kilogram per hour for 6 hours 24. What is a baseline creatinine level? A patient's typical creatinine level before illness, used for comparison. 25. What imaging tests are useful in AKI? Ultrasound to assess for obstruction and CT scans if a more detailed evaluation is needed. Management and treatment. 26. What is the first step in managing AKI? Identify and treat the underlying cause, e.g., dehydration, infection, or obstruction. 27. How is fluid management handled in AKI? Administer fluids for hypovolemia, or restrict fluids for fluid overload, based on the patient's needs. 28. What is the role of dialysis in acute kidney injury? It is used in severe cases to manage fluid overload, high potassium levels, or uremia. 29. Which medications are commonly adjusted or discontinued in AKI? Nephrotoxic drugs such as NSAIDs, ACE inhibitors, and certain antibiotics. 30. Why is nutrition important in AKI management? To provide energy, prevent muscle breakdown, and avoid worsening uremia or electrolyte imbalance. Complications of AKI. 31. What are common complications of AKI? Hyperkalemia, metabolic acidosis, fluid overload, and uremia. 32. How does AKI affect other organs? It can cause systemic complications like pulmonary edema, encephalopathy, or cardiovascular dysfunction. 33. What is uremia? The accumulation of waste products in the blood, leading to symptoms like nausea, confusion, and fatigue. 34. Why is hyperkalemia dangerous in AKI? It can cause life-threatening cardiac arrhythmias. 35. What are the long-term risks of acute kidney injury? Progression to chronic kidney disease or end-stage renal disease. Prevention of AKI. 36. What are key strategies for preventing AKI? Maintain adequate hydration, avoid nephrotoxic drugs, and monitor at-risk patients closely. 37. How can medication reviews prevent acute kidney injury? Identifying and discontinuing nephrotoxic medications reduces the risk of kidney injury. 38. What is the role of early warning scores in AKI prevention? They help identify patients at risk of deterioration, prompting early intervention. 39. Why is monitoring urine output critical? It provides an early indicator of kidney dysfunction. 40. What lifestyle changes can reduce the risk of AKI? Controlling diabetes and hypertension, staying hydrated, and avoiding overuse of NSAIDs. Case studies and practical scenarios. 41. What is the most common cause of AKI in the community? Dehydration due to illness or reduced fluid intake. 42. How does sepsis cause AKI? Sepsis causes vasodilation and reduced renal perfusion, leading to ischemia. 43. Why is AKI underdiagnosed in the community? Symptoms are nonspecific and may mimic other conditions. 44. How does contrast-induced nephropathy occur? Iodinated contrast media can cause direct tubular toxicity and reduced renal perfusion. 45. What is the significance of the osmolality gap in acute kidney injury? It helps identify unmeasured toxins contributing to acute kidney injury. Advanced Concepts 46. What is the osmolality of plasma in healthy individuals? 275 to 295 milliosmoles per kilogram. 47. How does AKI affect osmolality? AKI may lead to hyperosmolality due to retained solutes like urea and sodium. 48. What is the purpose of fractional excretion of sodium, FANA, in acute kidney injury? To differentiate between prerenal and intrarenal AKI. A FANA of less than 1% suggests prerenal AKI. 49. What are the benefits of peritoneal dialysis over hemodialysis? It can be performed at home, is gentler, and requires no vascular access. 50. How does AKI progress to chronic kidney disease, CKD? Persistent kidney damage or incomplete recovery from AKI can result in fibrosis and chronic dysfunction.